Hello, this is part 3 of heart failure series. We'll continue talking about heart failure, and we will start with diagnostics of heart failure. So, to diagnose heart failure, we have to assess ventricular function, and we can do it by measuring the ejection fraction. This we can do with echocardiogram. We can measure the cardiac output, and it will give us type and severity of the heart failure. Also, by using cardiac catheterization with radioactive radionuclide, we can measure the cardiac output and ejection fraction. So also we'll get chest X-ray. Chest X-ray will show us the congestion in the lungs, and it will also show us the hypertrophied heart. Hypertrophic heart. Electrocardiogram, if the person has heart failure, most likely they have arrhythmias, and we'll see what kind of arrhythmia they have, heart block or another heart block. Maybe it's ventricular tachycardia. We can do the cardiac catheterization, where we'll see the coronary artery and may find some ischemia, which leads to heart failure and can lead to arrhythmias. And stress test. We can pull some labs on the person. So we'll see the kidney function, the perfusion to the kidneys, the kind of important, how they are working. Are they eliminating the fluids, or are the renin keeps being released and kidneys being overworked by ADH and aldosterone, and by what else is there? Renin, angiotensin 2. So by those things, and we'll see the disbalance in the electrolytes, serum electrolytes. So the sodium will be higher, above 150, above 145. Above 145 is the serum sodium. Yep, above 145. Then bilirubin, urea, nitrogen will be elevated, so above 120 milligram deciliter. And then creatinine above 1.1 milligram deciliter. Beta natriuretic peptide. Actually, beta natriuretic peptide helps lower stress on heart. It actually works on the kidneys, trying to diurese the body, so tries to lower the fluid in the body. It antagonizes antidiuretic hormone, trying to inhibit that one. But because there's enzymes in our body, it breaks down our beta natriuretic peptide. It's not that effective. So anyway, the levels will be higher for beta natriuretic peptide with heart failure. Thyroid stimulating hormone, we can do that. Complete blood cell count, we can do that. and urinalysis, we will see excretion of more of creatinine, and bond concentration will be higher. Alright, what do we have? So next we'll move on to the treatment of heart failure. Where is here? Not good. Not good. Okay, so treatment of heart failure. So we would eliminate all the contributing factors of heart failure. If the fibrillation, atrial fibrillation is the problem, we would work on that. We will try to fix the arrhythmias. The person's drinking, of course, we'll try to fix that. The goal would be to decrease the workload on the heart, decrease the afterload, and decrease the preload. First, of course, the lifestyle changes. After that, we go to the drugs. So if it's systolic heart failure, to be honest, any heart failure, systolic, diastolic, left, right, we'll use ACE inhibitors. Increased creatinine impairment. So we'll start with ACE inhibitors. If it leads to renal impairment and the person keeps retaining the creatinine and keeps retaining the potassium where it goes above 1.5, then we will switch to ARBs. ARBs are angiotensin receptor blockers. So our angiotensin, everywhere it binds to, those receptors will be blocked by these drugs, and they end on sartans. Hey, I wrote some notes over here. So for ACE inhibitors, what they do, they promote vasodilation, and they diurese the person, and that decreases afterload and preload and afterload. So our ARBs, sartans, like a losartan, lowers blood pressure by also diuresing the person, vasodilating. Side effects: hyperkalemia. Okay, so potassium will be accumulating. Hypotension. No sense we have low fluid. That will lead to hypertension and renal dysfunction. Well, we got some kind of toxic effect on the kidneys, or probably just overworking the kidneys. So hydrolysine vasodilator, and isosorbide dinitrate cause vasodilation. So we have our capillary, and so hydrolysine will dilate arteries, or more precisely arterioles, and then isosorbide dinitrate, nitrates. Everything is nitrate, nitroglycerin. They would dilate the other side, the venous side of the blood vessels, and thus lower the preload. We have our diuretics affecting the loop of the nephron, and they block the reabsorption of fluid one way or another, whether it's spironolactone, that potassium sparing, or whether it's Bumex, that works in the loop of Henle. Those beta blockers, they basically block that sympathetic response, slow down the heart rate, and some of them, like carvedilol, will dilate the blood vessels, more like systemic effect. And also lowers the low density lipoproteins. Carvedilol will work on the blood vessels, but something like metoprolol, that is, I think, second generation beta blocker, it will have only effect on the heart. So carvedilol on both blood vessel, but metoprolol on the heart. So when you give metoprolol, please do check the heart rate. But there's less worries that it will dilate the blood vessels. Depends on the amount too. So also, again, in cardiac drugs, digoxin, digitalis, digoxin, lanoxin can be given to the person. It's like a fourth stage of medicine, fourth level of drug administration. We start with ACE inhibitors and progress slowly, adding drugs. This one probably last stage, digoxin. It will slow down the heart, slow down the impulse, propagation of the impulse, and then it also will increase the contraction of the heart. So that will help with heart failure and increase the work of the heart. So it lowers the conduction through the AV node, atrioventricular node, and then it also increases the contraction. It relieves edema, removes fluid, but digoxin is very toxic and very fastidious medicine. When body has low on potassium, effective digitalis are enhanced. The thing is, the heart has receptors, usually potassium binds to them, but digoxin also wants to bind to these receptors. So when it will bind to this one, let's say, it will bind to this one and have its effect on the heart. So for example, when there's less potassium, more receptors are available for digoxin to bind, and digoxin will come bind to this receptor, and usually, let's say right here, where usually potassium sits. Again, there's less potassium in the body because somebody patient took too many diuretics. That receptor is available, and digoxin will bind here too. So there's too much effect of the drug onto the heart, and too much effect produces the toxicity. So a person will experience fatigue, depression, malaise, vomiting. There's too much of the drug. Person somehow maybe affects the brain too, but the person will see, or the eyes, person will see the greenish yellow halos around the objects, will experience arrhythmias, the rhythm will be changed, and snowy vision. So there will be snowy vision. Signs of effectiveness. Well, if digoxin is working, we'll see decreased dyspnea, basically realization of the heart failure, decreased crackles, decreased pulmonary peripheral edema, weight loss, increased activity tolerance. We have to monitor kidney function. They are the one who eliminate digoxin. Oh, there we go. If the kidneys are malfunctioning, then we will have increase in digoxin. So, and the labs that monitor the kidney function are creatinine in the serum and urine, and bilirubin, urea, nitrogen. Also we can give calcium channel blockers such as verapamil, nifedipine, and diltiazem. So Zems, Dipines, well, Pamils, all calcium channel blockers. They are contraindicated with the systolic dysfunction and can be taken with diastolic dysfunction. Alright, I will continue in the next video. Thank you for watching.